homework given by Gopakumar sir on
Sir, am I, my PPT
Yes,
visible, sir?
yes,
yes.
visible, full screen, make it full screen.
Yes, sir. Yes, sir.
He's from the institute where maximum Ilizro work is done. So it would be good that limb orientation, alignment, everything is covered by him.
No,
Yes,
sir.
sir. I'll try.
Draw Pale's book, sir.
Yes, sir.
Yeah, but Kulkarni and Veeraj and Ruta ma'am being the president this year of Asami.
Yes,
Yes,
go
sir.
ahead.
Good evening, everyone. Yeah. Good evening, everyone, sir. Today's my topic is on limb alignment and orientation of the lower limb. So, first of all, the introduction. A stick figure, as you can see in the diagram. Sir, excuse me. Can you see my cursor?
Yes, yes, you go
Yes.
ahead.
Okay. Okay, sir. A stick figure can be used as a schematic diagram for a complex three-dimensional image of a person. Similarly, axis on the joint line can also be used to describe alignment and the joint orientation of the bones of the lower limb. So now, first of all, we'll talk about the mechanical and the anatomical axis of the lower limb. As per the definition or as per the what is the mechanical axis? Mechanical axis is defined as a straight line connecting the center point of the proximal and the distal joint. So if we want to draw mechanical axis of the femur, then the mechanical axis would be from the center of hip joint to the center of knee joint. And if we want to if we want to draw the mechanical axis of the tibia, then it is from the center of the knee joint to the center of the ankle. It is always a straight line in any plane, and mostly it is defined in frontal plane mostly. Okay. Now, second is the anatomical axis. Anatomical axis is the mid diaphyseal line of that long bone. Mainly for a straight bone, it is a straight line, but for the exception is a femur, where it is a curved bone in the sagittal plane. So the mid diaphyseal line would be a curved in case of femur in the sagittal plane, defined in both the planes. Then the question arises: how do we draw the anatomical axis of the lower limb or the any long bone? So we have to take in the diaphyseal region any two or three points of the cortex, outer cortex and the inner cortex, or the and then we have to we have to draw the line at that point, and from that center of that point and connecting all the points would give us the anatomical axis of that particular long bone. Now talking about the tibia. Now talking about the tibia, the mechanical and the anatomical axis of the tibia are for the practical purpose as taken as same, but if theoretically they are not exactly the same. Anatomical axis of the tibia is slightly medial to the medial mechanical axis, and it intersects the knee joint at the medial tibial spine. So if you see in the diagram, in the A diagram, the mechanical axis of the tibia is drawn, which is passing towards from the center of the knee joint to the center of the ankle joint. But if you see from the anatomical axis, it goes from it is a mid diaphyseal line which goes from the medial tibial spine and the center of the ankle. So the difference, there is very minor difference in the distance of the mechanical axis and the anatomical axis of the tibia. So for the all the practical purpose for the tibia, it is taken as the same because the difference is very minor. Next. Next, I would like to talk about the femur. The femur, the mechanical and the anatomical axis of the femur are not parallel. As I said earlier, the mechanical axis of the femur is mostly taken in the frontal plane, while the anatomical axis can be taken both in the sagittal plane, and most in the sagittal plane as well as in the frontal plane. Now, talking about the femur, anatomical axis intersect the knee joint 1 centimeter medial to the knee joint center point near the tibial spine, the same as of the tibia. Proximally, the anatomical axis of the femur proximally it passes in the medial to the GT in the piriformis fossa. So as you see in the diagram, when I in the first diagram in the towards my left, it is first is the mechanical axis which is drawn from the center of hip joint which is at the and from the center of the knee joint. I'll tell you later how the center point of the joints are identified. So this is the mechanical axis of the femur. Next, there is an anatomical axis in the second diagram. There is a center diagram. There is an anatomical axis of the femur, which is drawn as a mid diaphyseal line. If we exemplate the line proximally or distally, as I said in the description, proximally it will pass to the medial of the GT, and distally it will pass just to the medial tibial spine. Okay, and then the difference between the mechanical and the angle between the mechanical axis and the anatomical axis of the femur is which is called as anatomical mechanical axis, which is 7 plus or minus 2 degree. So mechanical anatomical axis is valgus or lateral to the mechanical axis. Next, I would define the joint center point. What are the joint center point of the hip, knee, and the ankle? So the mechanical axis passes, as I said, the mechanical axis passes through the joint center point. Mechanical axis is mostly considered in the frontal plane. So mostly we will, for any deformity correction or any for the practical purpose, we would see, or for the surgery such as total knee replacement, we would see the mechanical axis in the frontal plane. So we need to define frontal plane joint center point of hip, knee, and ankle. So now I'll talk about the how to come to a how to draw or how to come for a center point of the hip joint. So the center point of the hip joint is considered as the center of the circular part of the femoral head. As I said, as it can be seen in the diagram, it can be as a center of the femoral head. How it can be identified or how it can be, we have to quantify. It is by the with the help of Moses circle, or we can easily use the circular part of the goniometer, as in the seen in the diagram. Next, I would talk about the center point of the knee joint. The center point of the knee joint is approximately the same. We of whatever the point we take, and the point can be taken as the top of the femoral notch, the midpoint of the femoral condyle, the center of the tibial spine, the midpoint of the soft tissue at the knee joint, or the midpoint of the tibial plateau. The corresponding diagram and the distance, if we can take any point as a reference point for the center of the knee joint, because all the points are more or less in the same line or in the very near to each other. So we can take any, and for the practical purpose and for easy uh, this thing, we take mostly the center of the femoral condyle or the apex of the femoral notch. For the practical purpose, we take that as the center of knee joint. Next is the center of ankle joint, center point of the ankle joint. So center point of the ankle joint is taken as a mid width of the tibia and fibula at the level of the plafond, or the mid width of the soft tissue around the ankle anteriorly, or the mid width of the talus. So in the diagram, as in the case of the knee joint, all the points can be taken into consideration to consider the center point of the ankle joint. And for the practical purpose, we take the tibia fibula center point of the tibia femoral distance at the level of the plafond. Okay. Next is the mechanical axis, anatomical axis, the center point of the ankle, knee, and hip joint orientation line. So now how we can draw the joint orientation line, and what is the joint orientation line? A joint orientation line can also represent the orientation of the joint in any plane. It could be in the frontal or it could be in the sagittal plane. So how we can draw the joint orientation line? So first I'll talk about the ankle. Ankle in the frontal plane, it is drawn as the from the line passing through the subchondral area of the tibia plafond or the dome of the talus, as is in the seen in the diagram, first diagram besides ankle. In the sagittal plane, it is drawn by passing the line anterior and posterior lip of the tip of the distal tibia. Yeah. Then in the knee joint, in the frontal plane, in the frontal plane, in the knee joint, it contains two joint orientation line, one at the level of the proximal tibia and one at the level of the distal femur. So first I'll talk about the proximal tibia in the frontal plane. The frontal plane proximal tibia, the joint orientation line can be drawn through the concave, or the line passing through the both the concave surfaces of the tibial plateau. Then in the sagittal plane, it is through the flat subchondral tibia, the line passing to the flat subchondral area of the tibial plateau. Now, in the second joint orientation line in the knee is at the level of the distal femur. So in the frontal plane, the distal femur, it is drawn. It is drawn by line passing through the convexity of the femoral condyle, as it is very well seen in the diagram. And in the sagittal plane, as the condyles of the femur in the sagittal plane uh, are not straight. They are rounded. So we have to take we have to take the point where the two condyles meet at the metaphysis region, and that we can make the joint orientation line in the sagittal plane at the level of distal femur. Or we can, if the growth plate is not, if the growth plate is open, then we can see the epiphysis metaphysis junction. We have to take that point as the orientation point and then draw the line connecting the 2 points. So with the joint orientation line in the sagittal plane at the level of distal femur for the knee joint. Next. Next, I would talk of the hip joint, how joint orientation line in the hip joint are formed. So in the hip, there are two lines formed in the frontal plane as well as in the one line sagittal plane also. So in the hip, there is one neck of the femur line. In the first diagram towards my left, it is in the frontal plane. It is the line through the center of through the mid diaphyseal point in the femoral neck. This is the line. It is passing through the center of femoral head through the center of the mid diaphyseal area of the femoral neck. The line which is drawn by connecting these 2 points is called the neck of femur line. Next, then the joint orientation line of the hip joint. It is the line which is drawn by connecting the 2 points. The first point is at the tip of the greater trochanter, and the second point is at the center of the femoral head. The line which is drawn by connecting these 2 points would be a joint orientation line of the hip joint in the frontal plane. So after completing all the mechanical, anatomical axis, joint center points, and the joint orientation line, then I would like to go for the joint orientation angles. So as we have any angle can be formed by connecting the two not by connecting between the two lines, we can get an angle. So what is joint orientation angle? The angle formed between the joint line and with either the mechanical and or the anatomical axis is called the joint orientation angle. What do you mean by this is that any joint reaction joint orientation line can form an angle either with the mechanical axis or with the anatomical axis. So mostly the mechanical axes are taken into the frontal plane, and anatomical axis can be taken both in the frontal plane and the sagittal plane. So there are fixed normal values of the joint orientation angle, which I would like to go for, and there are and there are and they are defined as, the first would be, as we will talk about the mechanical joint orientation angle as per the mechanical axis of the lower limb. So I would like to revise the mechanical axis of the lower limb, as it will be passing from the center of the hip joint to the center of the ankle joint. That would give us the mechanical axis of the lower limb. So now, and then we have to draw the joint orientation lines, first at the hip joint, the knee joint, and one at the ankle joint. So now the angles we will get at all the three levels, that is at the hip joint, knee joint, and the ankle joint. So we'll have to uh, determine the angles. So lateral proximofemoral angle is given a value is 90 degree. Normally it is 90 degree. The range is 85 to 95, but in a normal adult it would be 90 degree. Next thing, anywhere in the angle, say lateral proximal femoral angle and medial proximal femoral angle, both will give us a total of 180 degree. So any one angle we know, we can get the other angle. So in this case, it would be 90 degree. Next there will be mechanical lateral distal femoral angle we have to remember. So that is 88 degrees, where the range is 85 to 90 degree. Here the M in the short is correspond that the lateral distal femoral angle is as per the mechanical axis. Will come later, which is that anatomical axis. But the lateral distal femoral angle from with respect to mechanical axis of the lower limb is 88 degree. So the uh, me, uh, medial distal femoral angle as per the mechanical axis would be 180 minus 88. That comes out to be 92. So we can get one value and we can get the other value. We have to remember only the one values of each joint. Next would be medial proximal tibial angle. Now in case of tibia, mechanical and the mechanical and the anatomical axis both are taken as one. So there is no nomenclature of medial or anatomical we have to put. So medial proximal tibial angle is 87 degree. So lateral proximal tibial angle will come out to be 180 degree minus 87, that would be 93 degree. But for practical purpose and for planning, we should remember only one values at each sides of the distal femur, proximal tibia, ankle and hip joint. Similarly, distal tibial angle comes out to be is 89 degree, range is 86 to 92 degree. Okay. Then at the one more point, at the knee joint, this between the, as I said, with the knee joint, there are two joint orientation lines at the level of distal femur, at the level of proximal tibia. So mostly they are very much parallel, but there is a minor 1 to 2 degree of angle between these two lines, which is called as joint line conversion angle. That you have to remember, which is 0 to 2 degree. Okay. So similarly, I will again repeat mechanical axis. We draw now the angle according to the mechanical axis, and we draw the joint orientation line. Joint orientation line at the hip joint, two at the knee joint, one at the ankle joint. Then we measure the angles. The normal angles of the lateral proximal femoral angle is 90. Lateral distal femoral angle is 88. Medial proximal tibial angle is 87, and lateral distal tibial angle is 89. And the joint line congruence angle is 0 to 2 degree. Mostly it is parallel. Okay. Now, similarly, anatomical axis of the lower limb is by joining the mid diaphyseal line of the femur and the mid diaphyseal line of the tibia, as it can see in the center figure. And we can get the similarly we have to draw the joint orientation line at the tibia, at the hip joint, the two at the knee joint, and one at the ankle joint, and we will get the angle. So medial proximal femoral angle will be 84. Then anatomic lateral distal femoral angle is 81. As there is a difference, as I said earlier, and the difference between the anatomical and the mechanical axis of the femur is 7 degree. So 81 degree, and that was 88 degree mechanical axis. This comes up to be 81 degree. Then medial proximal tibial angle would be same as that from the mechanical axis, because in the tibia both are same. That comes out to be 87 degree, and lateral distal tibial angle comes out to be 89 degree. Okay. Similarly, mostly the mechanical axis is drawn mostly in the frontal plane, and the anatomical axis is drawn both in the frontal plane as well as the sagittal plane. So sagittal plane, we will take the anatomical axis into consideration. So posterior proximal femoral angle would be 90 degree. Anterior proximal tibial angle, anterior proximal femoral angle would be 170 degree. The next would be posterior distal femoral angle. We have to remember as 83 degree. Similarly, posterior proximal tibial angle, we have to remember 81 degree. And anterior distal tibial angle, we have to remember 80 degree. It's a bit, the values we have to bit today, but these are the normal values assigned for as per the joint orientation angles, as per the anatomical, mechanical, and both in the frontal and the sagittal plane. Next. Now there are two nomenclatures which are used is anatomical axis joint center distance. So
Yash, this is too detailed.
okay, sir,
This
I
thing.
can skip this.
We can skip this.
Yes, sir. So now I would like to talk about an important topic, which is important measurement, which normally has to be taken in any deformity correction or planning of a TKR also, whether the lower limb is in valgus or the varus. So that is called as mechanical on the whatever to mechanical axis deviation. So normally, as I said earlier, mechanical axis of the lower limb passes from the center of femoral head to the center of ankle, and it just passes just medial to the center point of the knee joint in the vicinity of the 1 centimeter. As I said in the as you can see in this diagram, mechanical axis of the lower limb passes from center of hip joint to the center of ankle, and it is just medial to the center point of the knee joint, which is around 1 centimeter. So if during the planning, if this mechanical axis does not pass through the medial of this center of the knee joint, that means there is a mechanical axis deviation. Now the distance between this mechanical axis line, I mean to say this mechanical axis line and the center of the knee joint, this distance in the frontal plane is mechanical axis distance. Okay. Normally it would be around 8 to 10 mm, or it is within the 1 centimeter or 10 mm, which is normal. If anything below, above and below this would be an malalignment, which is discussed either as medial, which is varus, or lateral, which is valgus malalignment. So mechanical, see in that, I would like to explain this from this diagram. First diagram is a normal diagram in which the mechanical axis passes just medial to the center of the knee joint. Here the mechanical axis, the red line mechanical axis pass of the lower limb passes very much lateral to the knee joint. That means the lower limb is in valgus. And here, as in the third diagram, the mechanical axis of the lower limb is very much medial to the center point of the knee joint, which means the lower limb is in the varus. Now, again, we have to see tibia femoral angle also we can come to know. Then the tibia femoral angle, which is according to the mechanical axis, or we can say the anatomical axis. So we have to draw the mechanical axis of the femur, mechanical axis of the tibia, and what we will get is according to the mechanical axis, there will be difference of 1.3 plus or minus 2 degree. Similarly, we have to draw anatomical axis of the femur, anatomical axis of the tibia, and we get the there is a difference of 6.8 degree plus or minus 1.4 degree. So to summarize, standard measurement, I would just like to. So first we have to see draw the mechanical axis and the mechanical axis of the lower limb and the joint orientation lines. Then we need the anatomical axis of the femur. Then we get the angle. Then there is a 6 degree of valgus, as I said, in the mechanical axis and the anatomical axis of the femur. This is the neck shaft angle. This is 87 degrees. This is just to summarize. 87 degree as per the mechanical axis and 81 degree less lateral distal femoral angle as per the anatomical axis. This 87 degree is medial proximal tibial angle. 90 degree or 89 degree at the ankle. This the distance of 10 millimeter, as I said, mechanical axis distance. Similarly, in the sagittal plane, and according to the anatomical axis, anatomical axis. So in all this mechanical axis and angles we have to take into consideration while planning for a deformity correction. Mainly deformity correction can be planned by taking into consideration mechanical axis or anatomical axis, but both cannot be taken into consideration simultaneously. So as per the deformity, we have to consider we should know the normal angles and the normal distance and the normal values. So that we can where the deformity is, the planning can be. Sir, shall I stop share my screen?
Yeah,
Continue.
stop sharing. हो गया उसका?
Okay.
Yeah, Jan.
Yes, sir.
Yes, there was a nice presentation. Nice presentation. All the angles they have to
Axis
remember.
deviation. Yes, sir.
You're still in the hospital, sir?
No, no, still in the hospital, still in the hospital.
Oh,
method more, which is having so we have to take the longitudinal distance of the femoral head,
yeah, that is
and
what
then
is, that
the
is
there are three, yeah, and
mark
there
3
are three
points.
radius. We get 3 points, and from that we can come. I do not know
No,
exactly,
you
sir,
have to mark
but
2 points.
I read
You have
in
to
there.
mark 2 points at the maximum distance of the femoral head and one from the tip of the
Yes, sir.
trochanter. These 3 points together in a collinear, the center would be the center of the head.
Okay, sir.
So either you can take the maximum girth of the acetabulum on corresponding to that, the point on head, then draw a perpendicular to that, that should pass through the trochanter, tip of the trochanter. So that
Okay.
confirms the center of it.
Center of hip joint.
If the head is not deformed, you can do one more thing. You can draw a line from the foveal center going towards the shaft, and second from the tip of the trochanter. Where they intersect, it is the center of the head. These are two other methods. These are not described in Drawer Pele's book, but in Heisenberg's book, Heisenberg's book.
Gopa
Do
Kumar sir.
you
Yes sir, yes sir.
एक question, important recent advance का question. What are the softwares that are used in deformity correction or mechanical axis deviation? About that.
Sir, I got to know, but I could not find it, sir. I'll
You
find
could
it.
not find it. There are two softwares. One is a Bone Ninja software,
Okay.
and the other one is a multiplier method. Multiplier method is
Palace
basically, yeah. Tell what you were saying.
Sir, for limb length discrepancy, there is a multiplier. Palace multiplier method is there.
Yeah.
There are sort of like he has done the research on many patients, and he has got the standard values. We have to just put our patients' values, and we'll get the it is limb length discrepancy. Maybe from that it
Yes.
could be a software from.
Yeah, one. And for deformity, you have a Bone Ninja software in which you place the X-ray, and with the help of software, you can get the exact values.
Okay.
I mean, you have to draw it on the software itself, the mechanical axis and the head of femur, tibia, femur condyle, and then you get all the values by itself.
Okay.
So that is a Bone Ninja software, which is available only with Apple.
Okay. We have been using, sir, routine X-ray software, scanogram, and then on the computer, the routine.
Yeah, that is the Bone Ninja.
Okay.
Basically, Bone Ninja is iPhone. Karan has written correctly, and the other one is for Android apps. Multiplier.
Gopa Kumar
So
sir.
one was
Another thing, another thing that is used by this limb reconstruction specialist here, who is working with me, is that Oserix.
yes, sir.
I think Jain sir maybe. Yeah, Oserix is the one. It was
Yes, sir.
available free. Now I'm not sure whether it is available.
Everything is
There was
charged.
a trial version.
Everything is
Yeah.
charged nowadays, sir. It's 3,500.
Regarding the talk, yes, covered. Yeah, this Bone Ninja is only 4,000 rupees or 4,000.
No, sir. Now it is 1,200.
When I install it in my lab.
Now it is 1,200 only. Special discount
Yeah,
they've
yeah.
given
When
now.
I install it, 500 or something.
Yeah, sir.
Yeah. Then he has covered almost everything. Another question that was asked some years back in national board is malalignment test.
Because
And very few people wrote it.
malalignment test you have to understand. Otherwise, you can't calculate the how you know. Once you draw the line, that is the malalignment test. What Gopa sir is referring to. Just you tell me.
So malalignment test would be like first we have to see this. First we have to draw the center point of the all the joints. Then we have to join. First we have to draw a mechanical axis of the lower limb, and then mechanical axis of the lower limb, and then we have to draw the joint orientation line at the hip joint, knee joint, two at the knee joint, and one at the ankle joint, and then we have to draw the angles. that is lateral proximal femoral angle, lateral distal femoral angle, lateral medial proximal tibial angle, and lateral distal tibial angle. And we know the normal values. So when there is a deformity of our patient, we can come to know that this differs from the uh, uh, normal values. So we can come to know where the deformity is. And another thing, malalignment test, we can come to know is about the, sir, varus or valgus malalignment of the lower limb. So like mechanical axis mostly passes, as I said, in the from the medial to the center point of the knee joint. Around it will be in the vicinity of 1 centimeter. So if it is too medial than that, then it would be the limb would be in the varus. And if the mechanical axis would be far lateral from the center of the knee joint, then we can come to know that the lower limb is more or less in the valgus. So this
The
pre
students will not understand that. I think next week or something you can give a small presentation on malalignment test.
Yes, yes.
sir, I have put PPT. Can I share that? There is a this thing, sir,
I don't know whether
diagram.
Yes,
Sir,
yes, you can do
want-
that. I think we have time, sir.
Yes,
okay.
sir.
You can
Just-
put one diagram in the sagittal plane so that you can know that is the malalignment test.
So this is
Yes,
the diagram.
this was I was asking for. This one
Yes,
I was
sir.
asking for.
Sir, shall I
Because
explain,
you-
sir?
Yes, yes, go
Ah,
ahead.
explain it.
Sir, so malalignment deviation or mechanical axis deviation. So as we have seen, what is the first of all, what is the mechanical axis of the lower limb? So lower limb, we have to consider the femur and the tibia ankle. So the mechanical axis of the lower limb will be formed by from the center of the hip joint to the center of the ankle joint. Okay. So by we have to draw from the center of the hip joint to the center of the ankle joint. In between, it will cover the knee joint. So where it will pass the from the knee joint? In the knee joint, it will pass just medial to the midpoint of the center point. And where is the midpoint of the center point of the knee joint is in the tibial spine. This is lateral tibial spine. This is medial tibial spine. The center point of that is taken as the center point of the knee joint. So mechanical axis, again I'm repeating, mechanical axis of the lower limb will pass from the center of hip joint to the center of ankle joint. It will pass the knee joint just medial within the vicinity of 1 centimeter or 10 mm of the center of knee joint. So this is the normal alignment in every normal patient or in every normal person. Now, how we can come to know whether the lower limb is in valgus or in varus? For that, if take into consideration the second figure in the colored figure in the center. Consider this, the red line which is drawn, which my cursor is moving, is the mechanical axis of the lower limb. So as in this case, if you see the mechanical axis of the lower limb from the center of hip joint to the center of ankle joint is passing quite lateral, far lateral from the knee joint. Ideally, it should pass in the first figure. Ideally, it should pass as in the shown in the first figure, this one. But it is going quite laterally from the knee joint. So this indicates that my lower limb is in valgus. Next, if you consider again, I'm drawing the red line is the mechanical axis of the lower limb. It is joined from the, it is passed from the center of the hip joint to the center of the ankle joint. Here, as compared to the first, which is normal knee, normal lower limb, it is going far medial than the center of the knee joint. That means the lower limb is in varus. So this we have to take into consideration while planning any deformity correction or any TKR also. This is taken into consideration.
Yeah.
Am I correct, sir?
Yes. Basically, you have to draw first the center point of the hip and the center point of the ankle. Then you draw the line from there to there, and you must pass to the intended angle at the knee. If it is not matching at the knee, that means your mechanical axis is deviated. So now you have to draw the angles according to your reference, what you had mentioned in the proximal femur, distal femur, or the proximal tibia and distal tibia. Then only you will be understanding whether this defect is in the femur or in the tibia. So that's why you have to remember this angle. So first thing, mechanical axis deviation is from the hip to the ankle line. Then you know if it is not passing the knee, the deformity is either in the femur or in the tibia. Then according to the joint orientation line or the condylar lines, what you have mentioned to, if you draw the angles, then you have to identify whether it is in the femur or in the tibia. So this is the in short, this you have to remember and you have to answer this way. Understood? Am I correct, Jan sir? Jan sir?
बिल्कुल सर, 100% सर.
बस ठीक है, तो इतना तक समझना चाहिए सबको.
Yes, please unshare, stop sharing your screen. Yes, stop. Uday Kumar sir, your comments please.
Very good presentation, Yash Parekh. Very good presentation. Only thing is, everybody understand what are the angles, the nomenclature of the angles.
So everybody has to take a X-ray and has to draw it himself. Then only
Yes.
he will be able to understand these lines.
Yes, yes.
And
yes.
it's just not one day. Even now we make mistakes after so many years of doing deformity corrections.
Yes, yes. This is very
So
important for all the shortcuts discussions. Please remember that. For every genu valgum, genu varum, and Brown's disease, tibia vera, everywhere these angles will come. So every student must be very thorough with these angles. Good presentation, Yash.
Yes, yes.
Thank you, sir. Thank you, sir.
Thank you, Uday Kumar sir. Now I am requesting to the postgraduate students before taking final comments from Gopa Kumar sir to conclude today's session. Volunteers for next class presentation.
Case presentation, short case presentation of knee joint.
Knee joint case presentation. Sir, one is Mohanty sir student, Register Abhishek. He will present one case. I will have to just
Okay.
communicate with him. And any other volunteer for next class.
वो एक सैयद सलार था ना, उसने भी तो
सलार.
बोला था.
Yes, sir.
Hyderabad wala.
हाँ, हैदराबाद वाला.
But anyone who is present amongst the today's attendance, any students, please just unmute yourself and tell us.
I think
Shivananda is there, Gopal sir.
yeah, Sivananda sir is seen.
Is a login from some other mobile.
Sivananda sir.
He was traveling, that's why.
Yes, sir.
Another-
Shivananda, are you on the road? You are seeing what is the background we
Yes,
are
sir.
seeing?
Yes, sir.
Concluding comments from Gopa Kumar sir. Sir, please.
Yeah, today's class was excellent. The first topic was metabolic bone disease, mainly rickets. The boy has presented very well. The second was also very good. Only thing that was not covered in the second part is Cora. That can also be asked. So you have to read that up. That's all.
I think one more homework for the Cora.
Yeah, he can.
Along with this, whatever he is going to present in 2-3 slides, Cora, I think he should present 1 or 2 or slides.
Okay.
I think who presented today for this mechanical axis
Yes,
deviation,
yes.
he must present the Cora.
Right,
Yeah.
sir. Yes. That's what I am
Okay.
asking to him.
Okay, sir. Thank you.
Okay.
We'll give
Anything
him
else
some
from
time.
your side, sir?
Gopal,
Sir.
we'll give him some time. Let him prepare Cora along with that osteotomy rule 1, 2, 3.
He is working with Professor Kulkarni, isn't it?
Yeah.
There may be some X-rays available of deformity which they are correcting. So take one X-ray and just show us how they are doing this. That should be very good.
Yeah, we'll give him a separate class.
Is
for
very
that.
good.
Osteotomy rules also would be covered. They can give example of where osteotomy rule 1 was applied, 2 was applied, 3 was applied. Madam has lot many cases of that type. I know.
Yes, sir.
Or else I'll share 1 or 2 with
Okay,
you. Okay.
Right, sir.
That's good, sir.
It's very
Okay.
important.
Thank you, sir.
Bye bye.
Bye, sir.
Should we conclude,
Take
sir?
care. Take care.
Yeah,
Conclude.
bye.
Conclude. Yeah.